So you are Dr. Preeti Singh? So Dr. Nikita Oja will be presenting. She's a co-author. The chief author is Dr. Parul Mittal. Okay,
Should I start? Good morning, everyone. I am Dr. Nikieta Ahuja from AIOS Bhopal, and today I would be presenting a unique case of intraorbital wooden foreign body reaching the orbital apex and its successful management. So, ocular trauma is the leading cause of uniocular visual disability. Among trauma, intraorbital foreign bodies are common, with wooden foreign bodies being rare. Wooden foreign bodies present higher infection risk due to their organic nature. Pediatric ocular trauma poses a risk of amblyopia and long-term psychological damage. Effective management of complex pediatric cases requires prompt evaluation through imaging and multidisciplinary collaboration. I would be presenting to you a 5-year-old boy who, after 15 years post-injury from a fall, sustained right eye injury and from a wooden stick after an 8-foot tree fall. Presented with acute distress, proptosis, periorbital edema, patient was uncooperative for vision and ocular movements. As we can see, there is impingement with tissue desiccation. Examination revealed right lateral infraorbital laceration, visible wooden foreign body on the right infralateral side impinged at 7 o'clock, resembling devitalized tissue. Conjunctival ecchymosis and mid-dilated pupil. Posterior segment showed scleral indentation mimicking infratemporal RD. This is the picture showing intraorbital wood impingement at 7 o'clock position. With investigation, we first ordered for X-ray orbit, PA and lateral view for structural information. After that, on CT findings, we could see a foreign body from external orbital surface up to orbital apex, abutting the posterolateral surface of the globe, abutting right lacrimal gland and lateral rectus muscle. Optic nerve was appearing to be stretched. So for management, we proceeded with initial treatment with broad-spectrum antibiotics, topical moxifloxacin 0.5% and eye drop natamycin 5% with prophylactic tetanus toxoid. And surgically, we took the patient under general anesthesia and infraorbital laceration was widened and 4.7 centimeter wooden foreign body was successfully extracted. The primary repair was performed, and as you could see, there is a approximately 5 centimeter long wooden stick which was successfully removed. So on post-operative course, there was favorable recovery of vision and consistent retinoscopy reflex was observed in all the meridians. There was marked improvement in proptosis, resolution of retinal indentation with normal retinal appearance was found. So CT is commonly used but has limitation in detecting wooden foreign bodies. Prompt surgical intervention is critical for preventing severe outcomes like orbital cellulitis or abscess formation or brain abscess. Pediatric cases are extremely rare, with injuries extending to the orbital apex even less common. Previous studies like in Shelsta et al. And Tas and Top et al. Reported no significant pediatric cases. In these studies, there were sample size of 23 to 32 cases with none of being in the pediatric age group, with most injuries occurring in the young adult male from 21 to 22. In this case of a 5-year-old child presents diagnostic and therapeutic challenges not widely documented. Scleral indentation from intraocular foreign body impingement can mimic infratemporal RD, highlighting the need for careful differentiation. So to conclude, early diagnosis and multidisciplinary approach are essential. For managing such cases, high risk of infection due to porous nature of wooden foreign bodies necessitates early intervention, and favorable outcomes can be achieved with vigilance and thorough management. Thank you.
Thank you. A very good presentation. What was the B scan picture? Did you try an orbital mode of B scan?
Ma'am, actually, at our center before, if the patient was very uncooperative, and before operating such cases, we usually avoid B scan, or we, in some cases where it is important, we do gentle B scan.
No, this is a closed globe injury, right?
Yes, ma'am.
It's not an open globe injury.
And because the child was highly uncooperative, we did not go for a B scan. And on post-op POD day 3 to 4, we did a B scan and it did not show any, retina was on and vitreous was echoic, showing some PVD changes, and there was no CD or RD.
Yeah, orbital mode of B scan also helps, like in these cases, you know. Was there a choroidal abscess or any indentation? Like it helps us to know the diagnosis.
Yeah.
Anyway, well managed. Another point I would like to tell, like wooden foreign body is retained. There is a high risk of degradation and retaining foreign body chances also will be there. So thorough removal and measuring the size in imaging is very important. So any points you would like to add, sir?
I think you have said it rightly. Only thing I'd like to add is that when you're removing these foreign bodies, especially the wooden part, you need to remove it very slowly. Don't be in a hurry to remove it because otherwise you're likely to damage the surrounding tissue. So it's a take-home message that when you remove the foreign bodies, especially the wooden, of say about 5 centimeters, you said?
5 centimeters, yes.
So that's a big foreign body. So
Yes.
in order to avoid the damage to the surrounding tissues, do it with the forceps or with the help of course, always better to use forceps because you're likely to injure your fingers as well. Do it very, very subtle, very slowly in order to avoid the damage. And of course, I think yes, you rightly said the CT scan sometimes is a little difficult to go ahead with the wooden foreign body. I don't know if MRI can help.
So because
really-
it was an
I
But
don't-
emergency
the only
condition,
thing about MRI is that we have to be
Children.
very careful that it is a wooden only, it is not a metallic thing. So
Yes.
you, for a trauma, I would still feel that it is,
See-
because it's very difficult to ascertain from their history what has gone wrong at times,
So
especially
CT
the
with
children.
contrast will help, what I have
So
seen in
CT
my-
is
yeah.
always
Yes,
better.
that's right.
That
And 3D imaging and all now with advanced imaging, I think we can diagnose better. And if MRI again under sedation, for pediatric cases doing MRI
No,
is a
no,
challenge.
definitely
sir.
under sedation, but
And-
yes, contrast, and he rightly said that we are not sure what type of foreign body. If it is metallic, then you can't go ahead with the MRI. That's another drawback for that.
You know, I had a patient recently who had proptosis, and before we could think about anything, we were like, one of our doctors had written an MRI because we thought that there is something going wrong behind the eye. So the patient, the parent said that the child will not go into the MRI machine. CT scan took just 2 minutes. So CT scan is a very fast modality, especially in trauma cases. So that is
That is
very
true.
positive.
Right.
Sure.
Thank
Good
you.
Thank you,
presentation.
sir.
Yeah.
Thank you.